Dealing with childhood glaucoma is really challenging because they're tiny toddlers who can't speak, who can't say, and you can't examine them like how you examine an older child in slit lamp. So you really need a lot of strategies if you really have to examine them. So this small presentation is about how to deal with a child. So when you are dealing with pediatric glaucoma, you have a lot of responsibility at stake. You have to diagnose and manage them at the earliest. They're developing eyes. They require a lifelong IOP control. They depend on anesthesia. We need to have a very good anesthesia department to treat them. Their healing response is very aggressive, and their visual development is at stake. So obviously, the responsibility is very huge. So there are a lot of challenges when you're dealing with babies, toddlers, and children because they can't speak. That's what I said. And preoperatively, you have to need to have a good diagnosis and assessment to go ahead with the surgical planning. So I think the first one foremost is that you have to befriend the tiny one. From the moment you see them, you have to hold them so that the child should feel very comfortable with you. I think that's one of the things that I've always believed in, to be a friend to them and then their doctor later. So, there are alternatives to slit lamp examination. Even the child is most comfortable when the child is in the parent's lap. So all of us have got good phones now. You can take a video of the child speaking to them, talking to them, so they are not intimidated. And later on, then you can review the video and then at least have a broad idea as to what you are dealing with. My best technique is I let the child go ahead. I tell the parents at least go and play with the child. Feed them and then put the child to sleep. And when the child is sleeping, you can actually do a lot of things. You can do a very good sleep examination. You can do a application. You can do take the pressure measurement with an eye care tonometer, and you can do the eggshell length, and you can do everything basically what you would be doing under an examination under anesthesia. And that is how that you do most of the findings during when the child is asleep. If the child is not allowing you and the child is also not sleepy, you can also use pedicloral syrup, which is a mild sedative, to examine them and with a slit lamp. So actually, it is one of the most important parameters in diagnosing, if it is beyond the age normal, whether how bad the glaucoma is. Even if you cannot do an eggshell length with an A scan, you can always do a B scan and at least have an idea as to what is the length of the eye you are dealing with. So this is a short clip of the UBM. You prepared everything, and then especially in eyes which has dense corneal opacity, just put the probe and have an idea whether the entity chamber is formed or not formed. So these are the certain things may need to do with when you're dealing with a child. So that's the normal range, and if it's beyond that, then the possibility of glaucoma becomes higher. Which surgery? In an early PCG, maybe a goniotomy is a good procedure of choice. In moderate PCG, you might have to do a GAT, and in advanced PCG, you might have to do a combined trabeculotomy and trabeculectomy or a GDD. So the goals of surgery in children is to achieve a safe intraocular pressure control. You have to preserve the optic nerve. You have to maintain corneal clarity. You have to minimize the complication, and you have to reduce the reintervention. So this is a child who's an 8-month-old child. The axial length was like 24 in the right eye and 22 in the left eye. So the right eye was more severe. And then we tried GAT in this eye first, but the proline was not going. So we converted it to a goniotomy. If we can just hasten the video. Yeah. So you can see that the moment I was using a Kahoot dual blade to do the goniotomy, and then you see that the moment you actually incise, you can see a dense membrane falling off, and you can see the glistening white stems canal, and it's always a feeling of wow when you start seeing that. In the other eye, we did a GAT procedure. If you can just move ahead with the video. Can you help in? Okay. So in the other eye, we did a GAT procedure. For that, in order to stay in the angle, we use some amount of trypandulo, and then we use the viscoelastic, and then we could get ahead with 300 and 300 degree goniotomy. We could pass the Prolene suture, and the rest of the angle when it, because it became like a
osteum, we can go for needling. So this is just to revise our anatomy and the pathogenesis of failure in trabeculectomy due to fibroplasia, where proliferation of fibroblasts in Tenon's capsule leads to scarring, resulting into shrinkage and the built-in bleb. And then it is important to recognize the early signs of chronic bleb failure. Signs, there has to be local conjunctival hyperemia with excessive vascularization followed by rise in intraocular pressure, and there is loss of microcyst and eventual flattening of bleb. Now here we can see if we do not intervene, ultimately there is failure in the subset of patients. So how to determine whether bleb needling will actually help, as we did in our patient? If we have a nice patent ostium like this, then of course we can go for needling. But if it is blocked, like here, the iris is blocking in this particular scenario, also we can see the iris is blocking the ostium. In fact, as it is incomplete iridectomy in these subset of patient, we cannot do blood needling. Blood needling is not going to help, so better to go for a retrabeculectomy. So So how to perform? We can perform it early in immediate post-operative phase also, and a late also, where I inject the drug into the bleb area and make sure that it doesn't leak. So it can be performed under slit lamp also and under operating microscope also. So this is one is being performed under slit lamp. Here we can see this is localized encystment of the bleb, where you can go underneath the slit lamp. Although if you have to do extensive blood needling, it is always better to do it under operating microscope. So this was a very nice study from UK, where they found that blood needling they circulated the questionnaires, and 56% of the respondents they were doing in operation theatre, and some of the respondents, mostly 72% were doing with 5FU, and 22% were doing with mitomycin C, and the results were good with both the drugs. So these are few of the photographs pre and post bleb needling with 5FU. So take home message is that early recognition and signs of scarring is important. Appropriate treatment improves the success rate. Bleb needling, if planned and done perfectly, definitely leads to good results. Thank you so much for your kind attention.
Thank you, Shalini ma'am. As I keep saying, blebs are our primary babies that we start with, and you really care of them and you don't want to see anything happen to them. So these are, and now we have Dr. Rakesh Saket again, and sir, you'll be demonstrating deep sterectomy, a safer way of dealing with advanced glaucoma.
So that actually the session is actually slightly late, so I'm taking only 5 minutes. Right. So thank you again. My topic is slightly old because the nowadays the mix is actually favorable topic nowadays. But it is the non-penetrating deep splectrum is the safer way to dealing with the advanced glaucoma. So as you know, tuberculotomy is the gold standing now till date. So because it is due to the potent intraocular pressure lowering PKC and however the penetrating nature, so we can associate with the high risk of the complication as I actually discussed earlier. So the non-penetrating glaucoma surgery is the filtering surgery designed to lower the intraocular pressure while actually avoiding the full thickness entry into the antechamber. And second thing is the deep splectrum is preserve the integrity of the tubercular descent membrane. So actually, deep splectrum provide the favorable safety and the complication risk is slightly lower than tuberculosis. So actually, various modifications have been done to enhance the success rate of the non-painted deep splectromy, like the collagen implant, some sutures or the snubber clips, reflux, or some actually hyaluronic acid implant. So these are the video. I am going to this very economic technique. Please give the volume.
Trabeculectomy, which has been the gold standard glaucoma surgery till now, but penetrating nature of the trabeculectomy make it prone to several complications, many of which are sight-threatening. In the literature, various attempts have been made to preserve the scleral space under the superficial scleral flap, like collagen implant, reticulate hyaluronic acid implant, and viscoelastic implant. So I start in the conic space flap about 6 to 7 mm. Bleeders are then cauterized with bipolar weight with cautery. Marking is done with a caliper 5 into 4 or 4 partial thickness scleral incision with 50 number plate. So technically, a rectangle 5 into 4 mm superficial scleral flap is fashioned using crescent plate and dissected forward until the corneal periphery reached. This this raised flap is dissected 1 mm into clear cornea. The flap is hinged. A smaller, deeper second scleral flap is outlined and dissects forward until the Slem's canal reached. Then I shifted temporarily to clear corneal phacoemulsification, so AC entered with the 2.8 keratome. After extending of the anti-lens capsule, capsule access is done with the help of Utrata posture, followed by the hydrodissection, and then phacoemulsification by the stop and chalk technique, and PCL implantation is done after cortical aspiration. Then pilocarpine is used to construction of the pupil and hydrostitch done. Then I shifted superior side, and after that deeper scleral flap is dissected forward until the Slem's canal is open. Identification and opening of Slem's canal is the secret of success of NPDS. So here we can see aqueous percolation. Beyond this step, trabecular meshwork will be identified and percolation of the aqueous humor will begin. At this stage of the procedure, aqueous humor was seen to percolate through the remaining thin trabeculodescent membrane. Peeling of the Slem's canal enhanced the further percolation. The deeper scleral flap then excites the percolating aqueous will accumulate under the superior scleral flap, forming lac. This is called decompression space. Afterward, aqueous will flow into the subconnectable space and forming the bleb through the cut end of the Slem's canal, occasionally through the supraciliary space. After the 10-0 nylon suture, metal suture that extended 2 mm beyond the superficial scleral flap was secured under the flap. Suture is non-absorbable and widely available. After that, superficial scleral flap was deposited over the metal suture and secured with the 10-0 nylon suture with without releasable suture, and knot should be buried. And conjunctiva carefully closed with a interrupted 10-0 suture. We can say that this the simple economical step enhance the efficacy of the deep sclerotomy in lowering the elevated IB by adding the subflap method 1009 suture after excision of the deep scleral flap. The surgical technique is excellent in achieving the additional and adequate IOP control in this patient without use of long-term AGM, along with visual recovery as per the meet with their expectation.
So actually, this is a very safer and economic technique. But there are the many, but at the only one complication actually sometimes the trabecular attachment membrane is maybe perforate, and this is the very learning curve is slightly more in this technique. and it is slightly old technique where nowadays actually not performing the many by many the surgeon. So I saw the literature also. So this is my friend, Dr. Devendra actually did the deep splectrum with without emulsification in the 42 eye in the 30th patient, and also he conclude that the test demonstrate the potential use of the mitomycin C in the NPH alone with without emulsification as the valuable surgical option for the advanced glaucoma also. So it provides the significant IOP control and reduction of the AGM with good success rate and the favorable safety wave. And another, actually, I found the commentary on the non-penetrating lid splectomy. It concludes the it is of the safe technique for doing in the advanced glaucoma also. So this is actually the subclap matter suture is the very economic step. You can give the better results also. And thank you so much.
Thank you, sir, for the excellent, like the very intriguing, that's very new technique which I liked in NPDS to prevent the flap fibrosis. You put two sutures, so and that lake, the scleral lake which we are forming, it stays there. So it's very beautiful. I request Dr. Arshi ma'am to please felicitate our chairperson, Dr. Harsh Bahadur sir. Dr. Shatanshu Mathur sir, is he here, sir? Dr. Shatanshu Mathur sir. Dr. Shatanshu Mathur sir, yeah, are you here, sir? Dr. Smita Mehra ma'am, our panelist ma'am. Panelist ma'am, Dr. Smita Mehra ma'am. Dr. Smiti Jain ma'am. Dr. Amit Singh sir. Dr. Sunil Chaturvedi sir. Dr. Sunil Chaturvedi sir, are you here, sir? I think so. Okay.
Don't forget to pick up your favorite headgear or eye gear from outside before that thing starts. We'll just acknowledge some of our, faculty who's come all this way with a small few awards, and I need help from Shivam to come over. Shivam, can I take your help? They're going to play it? Okay. I think I don't know if everybody is inside, and maybe some people might be just outside. And I'll request Dr. Harsh sir and Dr. Oli sir to come and give a couple of awards, please. So Dr. Devendra, if he is here, I think he's gone out for a bit. Is he here? Okay, we'll go on to the next one and we'll come back to him. Can somebody call him up or something? So can you go to the next one? So yes, we have. I think there's a mistake in the designation. All the same, Dr. Sanjay Mishra, and I would request him to come over. We are very lucky to have him, and this is an old designation carrying on, uh, and legend in glaucoma care. So he's done some amazing work, and not just in glaucoma, because I hear things from across the country. He's been able to transform all the services on the armed forces. Everybody speaks so highly of him. He's been really a visionary for transforming. I hear that Lucknow is doing Smile, and they are doing femtocataract surgery, and all because thanks to his amazing efforts. Every MH is doing cutting edge work today, and they tell me that he never refuses when anybody requests for any new equipment or any new thing to come in. So I think we have to thank you for upgrading the facilities across the country. Thank you, and amazing work at R&R Hospital. Right, right. So that's what I mean. Cutting edge work happening at R&R, and all under his leadership, we've seen that transformation. Congratulations. So we'll go on. Okay, so we'll go back one step. So Dr. Devin Tuli, and we've known each other for a long time. We worked together in Guru Nanak Eye Center somewhere in the early 90s, and he's been very dynamic. We are giving him the Sentinel of Sight Award. He's a very active office bearer in DOS and also in our Guru Nanak Eye Center group. And please, Devin, and he's always ready to help and chip in. I think that's what I know him for. Always willing to. I'm going to request that this should be something like an annual thing with different specialities. You should have it. We are learning along the way, so it's an experience. And again, now very special award for Dr. Sunita Dubey, who does amazing work. Again, I think Dr. Sunita is no newcomer to Dehradun. I remember her coming here maybe 25, 30 years back when we were having our first glaucoma meetings, and she's been doing amazing work, always at the cutting edge. And also at Shroff Charity, she's again brought the glaucoma department to the top level in the country. And we are honoring her with the Beacon Light of Glaucoma Care Award. So I think another very special award, Dr. Sushma Tejwani, and we can also, give her a big hand. It's her birthday today, and yet she is here. She's, traveled all this way away from family, and we really respect that. And again, Dr. Sushma has been doing some amazing work at the Narayan Netralaya, and the Narayan Netralaya has been training so many fellows in glaucoma. And yeah, yeah. Thanks a lot, Dr. Sushma, architect of modern glaucoma surgery. Wonderful. So, with that, we'll go on to our next award. Again, somebody I've been working with very strongly for so many years, and I've seen him, transform a lot of care in AIOS. He's doing amazing work in Indore, very active on every scientific front, always forthcoming, always ready to help, doing very good work. I've heard his talks on mix, and it's like a learning experience as well. So, Amit, here we would love to honor him with the Innovator in Glaucoma Surgery Award. So, keep up the good work, Amit. All right, very befitting award, I would say, is the next one, Pioneer in Mix Award. So, Dr. Devendra Maheshwari, who has again traveled a very, very long way, and it's a very special effort. And he's also been, trainer for so many fellows, and Shivam has learned all under him and become a very good glaucoma surgeon as well. And we are really grateful for you to be traveling here. All right. So, as I was telling Dr. Rakesh Shakya today, I barely see him in India. I meet him, traveling, globe-trotting all over the world, teaching somewhere in South America or somewhere else. And he's a prolific surgeon, doing amazing work. Has done probably some of the highest volume surgeries overall in a day. I think many credits to him, and we want to, honor him with the Pathbreaker in Glaucoma Surgery Award. All right. So next award again goes to somebody who's very popular with her fellows, and I keep hearing her name all the time. So Dr. Julie Begu at the Shop Charity Eye Hospital, I think she does prolific surgery. Not just glaucoma. She does all complex surgeries, as my son Abhijay tells me. The torchbearer of glaucoma award for Dr. Julie. And congratulations and thank you so much for coming here against all odds. So we are grateful for Dr. Satanshu Madhu to be here. He's Chairman Scientific Committee of the North Zone Ophthalmic Society and a pillar of Uttarakhand Ophthalmic Society, both the societies which go behind. And Dr. Oli, who's one of our senior most past presidents of North Zone, who is organizing the new Uttarakhand State annual meeting in Dehradun this year in September, October. And we would love to have you, all of you, here for that meeting. And Dr. Harsh, of course, who's always been one of the pillars of Dehradun Ophthalmic Society and Uttarakhand Ophthalmic Society. So I think we'll go on with our awards, and I have lucky to have all the stalwarts here. Uh, Dr. Madhavi R. Pillai from the Eye Foundation in Vellore. Welcome and thank you so much for being with us. And IOP Control Warrior Award goes to her. And we are lucky to have all of us. With us. Okay. Again, I think somebody whom I really appreciate a lot, Dr. Shalini Mohan. She's been at the forefront of driving, ophthalmology in UP, in Kanpur, and in many territories. And now she aspires to go on the national front. And she's heading the Kanpur Medical College Ophthalmology Department, doing prolific work and very good. She's been a journal of the UP Journal. She's an editor for the UP Journal as well, and now moving forward, right? Wonderful. Chairman Scientific Committee of the. Congratulations. And then I think we'll go on to our next, faculty who's here. Yeah, Dr. Faisal Tattaruthodi, and he's at the Advanced Eye Center, PGIMR, and he's again a very gifted surgeon, as Sushmita and other people tell me. He's doing prolific work, and we would love to honor him with the IOP Control Warrior Award. So So that brings us to last but not the least, somebody whom I really appreciate all the time. He's always very dynamic, doing prolific work. I see him again at almost all our meetings presenting and with his amazing dressing style. And I recently saw pictures from last weekend where you were in that new The Joker outfit. And today I was hoping we will be seeing you in some other form, but more outside, right? So Prasanna, who's doing very amazing work in glaucoma surgery, makes and so many other things. Actually, I see him at the Mahatma Eye Hospital in Trichy, and we would love to honor him with the. He's also an office bearer in the UZ. So IOP Control Warrior Award for Dr. Prasanna. So we would like to also give away a couple of the faculty awards we've missed today uh, till now, and I'll request Dr. Arshi Singh to please come over. She is at the Guru Nanak Eye Center. Again, one of your senior residents was working with us, and she really appreciates all the work that you're doing. So please come over. And her mom is, ex-director of Guru Nanak Eye Center, Dr. Kirti, who's again a prolific glaucoma surgeon. Thank you for coming and thank you for being here. And I would request Dr. Ajay Agarwal to please come over and, he's been, I enjoyed your talk as well. It was lovely. Dr. Ajay is a professor at the AIMS Rishikesh. I think it never finishes. We have Dr. Sudhanshu all the way from Kashipur. We want to give him a chairperson award because he left during the session. We couldn't give it away to him. And again, one of our most dynamic people in Uttarakhand. Thank you.